Okay, good afternoon everyone.
Hi.
Hello everyone. So I hope you still wake up, yeah? Okay. So we are from Group 3, and my name is David Wijaya, and I'm from Indonesia, and my friend.
My name is Nur Iyani and I'm from Malaysia. I'm from Thailand. I'm Fadila from Indonesia. And I'm Gina from Indonesia as well. And this is our group.
Yeah. So today we want to talk Trogazo, and the active ingredient of Trogazo is ibalizumab. So ibalizumab means the immunomodulator, and then zumab, what you know before, is humanized. So more than 90% is human gain. So for the first, okay, the breakdown. So as we know, HIV virus is deteriorate the ability of our immune system to fight off life-threatening infection. And
so basically, HIV have 3 types, which is acute, chronic, and but after 2 to 3 years of being treated with the antiretroviral drugs, then the HIV virus itself mutates, so then it wouldn't be so effective to be treated with the antiretroviral drug because it becomes a multi-drug resistant HIV.
Therefore, Thai-made biologic incorporated made Trogazo that approved by US FDA.
Okay, and the API is ibalizumab, which is a monoclonal antibody. It is CD4 directed post-attachment HIV-1 inhibitor. What's that, did you ask? What's this? Do you know this? No? Okay, so before I explain all of this, let us familiarize ourselves with how the infection actually, with how HIV infects our T cells. Ding ding ding!
I think they're not ready for this.
Not ready for this. Okay, so we have our T cell. Okay, T cell, and then we have our CD4 receptor. Okay, in this CD4 receptor, we have domain 1 and domain 2. Okay, now we have our virus here. Okay, it targets the domain 1 of our CD4 receptor. Now, this binding conformally changes the structure of the CD4 receptor such that it makes a CD4 GP120 complex. GP120 is from here. Now, this complex, they signal, or they need a co-receptor. They signal a co-receptor such as CCR5 or CXCR4. It just differs in the glycoproteins of the T cell, which then helps with the RNA viral entry into the cell. It enters the cell, and then, as you know, viral proteins, they replicate in the host cell. Many RNA replicates, and then once so many of them have replicated and released, the CD4 T cell, they burst. Okay. Now, ibalizumab is different from other antiretroviral drugs. How they work. Now, before an infection happens, if we add Trogarzo or ibalizumab, they will bind to the domain 2 of the CD4 receptor. Okay, as you can see here. Now, once a virus enters to bind with the domain 1, okay, it still creates a complex. However, when they want to signal the co-receptor, it cannot. There's a steric hindrance created such that it blocks the interaction between the co-receptor and the GP120 CD4 complex. And then hence, the RNA viral protein cannot enter towards the T cell. Right? Now, with this, the virus will just go away because they cannot infect that cell. Bye-bye! And now, our T cell is strengthened. It's strengthened. Now, it is an advantage with this drug such that the B1 domain is actually also a receptor for the MHC class 2. Okay, the major histopathologic compatibility complex that is presented in the antigen-presenting cells. Now, let's say, pretend this is the MHC class 2. It binds with the domain 1 of the CD4 receptor, but then because this complex does not need a co-receptor, so signaling factors from the MHC class 2 can still go towards the T cells, which will induce more killer T cells. So the advantage of this drug is that it does not interfere with regular bodily immune functions. So in summary, it specifically binds to the domain 2 receptor of the CD4 lymphocyte. Specifically binds. That means, of course, there will be no other interactions with any other receptors in our cells, preventing the interaction between CD4 GP120 complex and thus blocking viral entry by steric agents.
Okay, so as mentioned before, people that are infected with HIV virus are usually treated with antiretrovirals. However, over a certain time, the HIV virus mutates itself and then it becomes resistant. So multiple resistant HIV. And for a solution to that, then So for a solution to that, they proposed Trogarzo as the solution. And this drug is actually recommended after the person have AIDS or they become resistant to any other antiretrovirals. It's not so recommended to use it while using the antiretrovirals, and it's not recommended for patients who haven't been treated with the antiretroviral to take Trogarzo first. And adverse reactions, there's actually not many. There's some of the adverse reactions include nausea, upset stomach, diarrhea, and a rash. And the severe adverse effects would be immune reconstitution inflammatory syndrome. So when a person is infected with the HIV virus, then that suppresses the CD4 T cells, as said before by Fanny. And so what that means is that then our body have less ability to fight off the infections that we have in our body, or either we have an infection but it goes undetected inside of our body. So yeah, in other words, it's just saying you have less white blood cells, and then but with the help of the Trogarzo drug that it binds to the CD4 cells, then the RNA of the virus cannot enter, right? So then the virus detaches itself from the CD4, and that can cause inflammatory because of the overwhelming response to it, because then there's an increase in the CD4 cells that causes inflammatory, and that inflammatory can cause even more severe damage to the already damaged tissues. So for dosage and administration, it is injected, so it's intravenous, yeah. And so for the first time getting Trogarzo, the patient is being injected of 2,000 milligrams of Trogarzo, which is a single loading dose at the very first. And then after 2 weeks after that, then it is followed by a maintenance dose of 800 milligrams for every 2 weeks. That's it. Oh, and for the availability, currently, because the drug is pretty new, our journal is also all from 2018. So they are currently just spread out in the US, but obviously you have to use a prescription from the doctor.
So now I'm going to talk about monitoring. Basically, when we talk about HIV virus, it will target the CD4 T cell. So there are three monitoring parameters, which is CD4 T cell count, CD4 T cell receptor, and also HIV RNA plasma level. Talking about HIV RNA plasma level, as mentioned by Fanny before, when the function of this ibalizumab is to prevent the attachment of the virus to the CD4 T cell. Thus, when it prevents the RNA from moving through from the virus to the CD4, thus the RNA cannot be replicated, and thus it shows the effectiveness of the drug. Then, as mentioned by Gina before, the drug is still in use and there is no adequate data available for the contraindication. Okay. I'm going to talk about pharmacokinetic. The first one, ibalizumab is a non-linear pharmacokinetic, which means it is zero order. Zero order can be shown by the half-life of the drug that will depend on the concentration of the drug, and also it will be affected by the amount of the enzyme. And thus, as ibalizumab means monoclonal antibody, thus it is not suitable to be given orally, and we give it intravenously for about 0.5 to 1.5 hour infusion. As the drug is targeted at the CD4 T cell, so the volume of distribution is quite high, which is 4.8 liter. And then, we increase the dose of the drug to 0.3 to 25 milligram, it will cause the clearance of the drug to decrease from 9.54 to 0.39, and also the elimination of half-life will increase from 2.7 to 64 hours. This is because the drug is dependent to the enzyme elimination. When the concentration is increased, so the drug can't be eliminated at a fast rate, thus the half-life of the drug will be longer. And ibalizumab concentrated reached its steady state level after the first 800 milligram maintenance dose with mean concentration over 30 milligram per milliliter throughout the dosing interval. And the drug and food interaction, there is still no significant data available.
Okay, so for the phase 3 trial, this study is sponsored by Thailand Biology in 2017. And the design, first is use a single group assignment and a single arm. It's open label, so the open label means like pharmacy and patients know about the drug, and the pharmacy already know about who the patient get the drug before. So for the first day, in the day 1, at in intravenous 2000 milligram loading dose. The loading dose is large dose that to rapidly achieve therapeutic concentration in the body. And in the day 7, it with OBR. OBR means objective optimized background regimen. Then OBR is like the antiretroviral drug, which sensitive to the patient. And in the day 21, it intravenous with 800 milligram in 2 weeks plus OBR for 24 weeks. So the purpose of this design for this study is to evaluate the safety and the effectiveness of ibalizumab in the treatment. So for the patient is consists of 14 participants and multi-drug resistant HIV type 1. So the kind of HIV is type 1 and type 2. Yeah, and type 1 is in around the world, and type 2 is especially is in the West Africa. Yeah. So the inclusion for the criteria of patient is no AIDS 3 months before screening, and then the viral load is more than 1,000 copies per milli, and the important thing is sensitive to at least one antiretroviral agent other than ibalizumab. Yeah, and so on. And the exclusion, there's many inclusion in this study, such as the pregnant woman and become pregnant or breastfeed, use alcohol, and so on. The outcome, the primary outcome is the viral load reduction as measure efficacy, and the secondary for the outcome, the time frame at week 25 or end of the study. So for the result, that show that in the study is 83% of the participant significant decrease in their HIV level after 1 week, and the others is the amount of the viral load of the participant below 50, 43% of patient, and below of 200 HIV RNA copies per milli is 50%, and patient who got adverse event reported that just only 9 patients, so they have a serious adverse event.
Yes. Next is the second type. This type is non-randomized parallel assignment, open label and multi-center. The object of this type is they compare two cohort study about safety tolerability of ibalizumab combined with optimized background regimen, and will provide continuing access to ibalizumab for patients completing a prior ibalizumab clinical trial. And the first cohort study, they used intravenous ibalizumab 800 mg every 2 weeks for combined with optimized background regimen for 48 weeks for patients who received that dosage before. And cohort study 2 is they used intravenous ibalizumab 800 mg every 2 weeks combined with optimized background regimen for 48 weeks for patients who never received ibalizumab. And next I gonna talk about the outcome. The primary outcome is about safety and tolerability of ibalizumab combined with optimized background regimen, assessed by the occurrence of adverse event and discontinue. And the secondary outcome is HIV resistance, effectiveness of viral suppression, and mean change in viral load. And finally, this type is there is no risk of host. And this is country validation that approved this that there are US, Taiwan, and Canada. This is our presentation. Thank you for watching.
Can we use this drug for initial treatment for HIV patients or?
No, we cannot use it for initial treatment, as mentioned in a slide before. That this Trogarzo can only be used if the other antiretroviral treatments are not effective. So, for example, like you first get HIV, and then so you cannot use Trogarzo immediately because it's a new drug, and it binds specifically to D2, right? So we can still use the other antiretroviral drugs because they're still effective. Now, the antiretroviral drugs are not effective only when the HIV virus, they mutate and they change their strains such that the antiretroviral drugs cannot be used. That's why we use the Trogarzo only when only when there is multiple drug resistant HIV. Any other questions?
Come on, guys. Do you guys have to start Trogarzo with a loading dose, or you guys straight start on a maintenance dose?
No, we start with a loading dose of 2,000.